Hi, Haroon. Thanks ever so much for asking me to participate in next year's British Association of Sclerotherapy conference. I haven't been for a while, so it'll be nice to catch up with folk. You've also asked me to put together this presentation to introduce myself a little bit and explain how I came to be interested in varicose veins, um, and latterly just to explain about our modern, if you like, technique for treating varicose veins with foam sclerotherapy. My interest in vascular surgery developed in the early 1990s whilst I was working in the operating theatres. In 1995, I was asked by one of the consultants to take up a role as CNS in vascular surgery. About the same time, one of our consultant interventional radiologists, a chap called John Henderson, suggested that I learn to ultrasound, and for the next couple of years, I spent one session a week with John in the X-ray department, scanning anything that moved. Veins, arteries, aortas, carotids, kidneys, I did the lot. This also coincided with the introduction of portable and affordable, or relatively affordable, ultrasound machines. This was the first machine that I had. This was Sonosite 180 Plus, and it basically transformed our assessment of patients with venous disease. Every patient who came to clinic got a scan, and we weren't left relying on educational guesswork and a handheld Doppler when looking at potential treatment for superficial venous incompetence. Everything really changed for me and took off when this chap, Andrew Bradbury, was appointed to the chair of surgery at the University of Birmingham. Andrew had previously been a consultant in Edinburgh, and he'd been awarded a large NIHR grant to investigate treatment of what was then called critical limb ischemia. He took up his post in early 2000, and he was looking for somebody to help him with this research. I applied, and I was fortunate enough to get the job. Now, the academic department of vascular surgery in Birmingham was brand new at this time. We had no money. So later in 2000, when we were approached by a company called Prevensys to participate in a clinical trial for which we would be paid, we jumped at the chance. Prevensys were trying to develop a commercial microfoam product for treating varicose veins, and were conducting a randomized controlled trial comparing their product, which was called Varisolve, with standard surgery. We randomized around 30 patients into that trial, half of whom received foam, half received surgery. Now, back in those days, we were taught that sclerotherapy for proper varicose veins really didn't work, and we had no expectation that the foam would be any different. So we were amazed when we saw the results. Indeed, we were so impressed that we decided to continue using homemade foam after the trial had ended. Prevensys continued to develop their Varisolve product. It took them many, many years and hundreds of millions of dollars, and is now known as Varithena. As far as I'm aware, the only country in the world where this is licensed is the United States, but I may be wrong on that. At this time, Philip Coleridge-Smith was also using foam to treat varicose veins, and I visited Philip in his clinic very early on, and we learned an awful lot from him and his team. Indeed, we've worked closely with him ever since, running many training workshops over the years. We were an academic department, so we tried to introduce foam in a scientific manner. Of course, we had to go through the hospital's Novel Therapeutics Committee, and I kept comprehensive records of all of our treatments for many years. We also supported several venous research fellows, including Katie Darville and Hugh Davis. I personally followed all of our patients up with face-to-face appointments and duplex scans at 1, 6, and 12 months post-treatment and annually thereafter for several years, keeping accurate records. And this wealth of data facilitated the publication of many papers. By the middle of the noughties, foam sclerotherapy had become our method of choice for the treatment of superficial venous incompetence. When endothermal techniques were introduced, again around about the middle of the noughties for us, we quickly realized that these treatment modalities were very complementary. Another interest of mine is improving the lot of patients with leg ulcers. The ESCAR trial had told us that correcting superficial venous incompetence was beneficial in terms of reducing ulcer recurrence, but many of us who treated large numbers of leg ulcers also believed that it improved ulcer healing. And we published a couple of papers, admittedly only case series, which supported that view. So when Alan Davis and co. published the EVRA trial results in 2018, we were delighted to see that borne out, and we were very happy to be participants in the EVRA trial. Anyway, that's enough about me and the dim and distant past. Let's move on to the technique that we use for ultrasound-guided foam sclerotherapy today. When we did the Varisolve study, we were taught to use a single cannula at around about the level of the knee, inject the foam, quite large volumes of foam in those days, and milk the foam around up and down the trunk and into all of the various tributaries. We've come to understand these days that this is not very efficient, and we need to get fresh foam into all segments of the veins being treated. Nowadays, we aim to place a cannula every 20 centimetres or so. If we're treating the entire length of the great saphenous vein, for example, we'll often put 2 cannulae in the thigh and 2 in the calf, plus cannulate every significant superficial tributary, as we know that these are often the site of recanalization when veins recur. Cannulae are all placed under ultrasound guidance with local anaesthetic, and the patient is appropriately positioned on a couch. We do not use butterflies, as we find that these can cut out very easily, and we do not cannulate veins with the patient standing upright. Not all cannulae are equal. We don't like the safety cannulae. In our experience, the best cannulae to use are Optiva 2 from Smith's Medical. These are very sharp and low profile. They go into veins with thickened walls very easily. We use a combination of 18, 20 and 22 gauge cannulae depending on the depth of the veins being targeted. The longer cannulae go into the trunks, whereas the shorter 22 gauge cannulae are used for superficial tributaries. This is also a useful aide-memoire as we use lower concentrations of STS foam in the superficial tributaries. When all of the cannulae are in position, we lie the patient supine and elevate the leg to reduce the pressure in the veins, thus minimizing the dead space. We start injecting proximally and work our way distally. We do not attempt to compress the sphenofemoral junction or sphenopopliteal junction for 3 reasons. Firstly, it is very difficult to compress the superficial vein without compressing the deep veins, thus trapping foam in the deep veins. Secondly, even if we do manage not to compress the deep veins, when you release the pressure, you're likely to get a bolus of foam from the superficial veins spilling into the deep veins, which is obviously not desirable. And thirdly, even if you can compress the superficial vein whilst leaving the deep vein open, you simply don't stop foam spilling into the deep veins. You can always see bubbles in the deep veins, but this just gets protein bound and washed away. We inject small 2 ml aliquots of foam slowly, and we use the minimum required concentration and volume of STS, 3% for the trunks, 1.5% in the superficial tribs. We believe this minimizes the chance of respiratory or visual side effects. We ask the patient to perform active ankle movements between injections to flush the deep veins, and when the veins are full, we stop injecting. Once the veins have been adequately treated with foam, we compress the leg using wool, pair haft and a compression class 2 stocking. This achieves a nice balance of high ambulatory compression and lower but still adequate resting compression. We ask our patients to go for a 15-minute walk as soon as the stocking is in place before they go home. Thereafter, we ask that they walk for a minimum of 5 minutes each and every hour that they're awake for the first week after the treatment, to reduce the risk of venous thromboembolism. We ask them to wear the bandage and the stocking untouched for 3 days, after which time they remove the bandaging and continue to wear the stocking day and night for 1 week and then day only for a further 2 weeks. All patients are provided with written post-foam sclerotherapy instructions, which includes our contact details. We stress the fact that tenderness, lumpiness, and discoloration over the treated veins is not uncommon and is nothing to worry about. Patients are asked to contact us if they have any concerns. Thrombophlebitis is not uncommon and is often easily resolved by aspirating the sclerothrombus under local anaesthetic and ultrasound guidance. This usually produces immediate symptomatic relief. In our experience, this is best done between 2 and 4 weeks post-foam sclerotherapy when the sclerothrombus becomes gelatinous. We advise all patients that it can take 6 to 12 months to see the final cosmetic review after endovenous treatment. So that's a brief summary of the modern technique that we use to treat our varicose veins with ultrasound-guided foam sclerotherapy. We seem to have very good results. I've had the good fortune to travel quite widely teaching this technique, and I see a lot of people struggling with it. It is quite nuanced. It's a very subtle technique. I think it is more of an art than a science. One of the problems with foam is that there is no standard operating procedure, if you like, as there is with the endothermal techniques. And many people have many different techniques for doing foam, but this works for us. Our patients seem to be very happy with it. We've published patient satisfaction results, and at the moment we've got no reason to change what we do. So I hope that's been helpful for you, Haroon, and I look forward to discussing this with you further at the British Association of Sclerotherapists conference next year. Thank you. Cheers.